want to introduce you to the new study, which is called MOVE, and that stands for Motor Outcomes to Validate Evaluations in FSHD. That's a study that is led by Dr. Stadland and Dr. Tawil through the network, the FSHD Research Network, and conducted at several sites in the United States, and you will learn more about it. But our goal here in this, this short presentation is to tell you where it's being carried out, what the goals are, what is being done, and what to expect if you may choose to participate, and really what's new about this study, because as you may have learned yourself by participating or hearing about it, there have been other natural history studies, but what's so exciting about MOVE? That's really what we want to talk about. Let me see here. So yeah, so what is MOVE? MOVE is a clinic-based observational study to evaluate the change of symptoms and function and signs of FSHD over a time period of 3 years in people with FSHD. And you may wonder, what is, first of all, you may know that what is an observational study, and June alluded to natural history, which basically just, we try to learn how does the disease change over time and what is the variability of the disease. And sometimes we like to learn about mechanistic questions about the disease as well. And that's been done previously, but why do we need another one? What is different and new about MOVE? What we learn typically is how people are affected. We learn about the spectrum from the person who's most severely affected to the person who's mildly affected. We also learn in natural history studies how genetic characteristics predict disease and how to measure disease severity, specifically as it changes. And there are two problems with that. Now, here, what I want to show you is problem number one. There are important motor milestones that some people reach throughout their lifetime with FSHD, and those include, for example, let me just bring this up. Laser pointer here. Those include, you know, at some point in their life, some people with FSHD need to use ankle braces, some need to use a walker or wheelchair. And those events or those milestones of disease progression occur rather infrequent throughout a lifetime. And, you know, a decade can elapse or even more time before someone may need a walker. And that occurs in one person. The other person might have a milder form of the disease and only use ankle braces at older age. Now, the third person might have even more a milder form and may never use those devices or a wheelchair. And we know that from cross-sectional studies that there's lots of variability. What we don't know exactly yet is what predicts, what is the difference between person one and person two, and how can we predict how the disease will behave throughout the disease course in a lifetime. And so one question is, how do those motor measurements, those outcome measures that we do, check your muscle function and your strength, and we have you do a number of activities during our study visits, how do those relate to the risk of having the need to have any of those devices used in their lifetime? And the other issue with that is, so first of all, the predictive power of our motor measurements and outcomes. The other problem is that here you see, if you have a natural history study, you know, like right here, that goes over typically 2 years. And, you know, again, this MOVE study is outlined as 3 years, but hopefully will go longer. This is a short period of time in terms of FSHD because there, you know, things progress slowly, very slowly, and some people a little faster and some other people. And so we might, when we do a study right here, we will never capture these items, these milestones, because it's just such a short period of time. And now the question is, how does MOVE overcome this problem and assesses this question? So MOVE enrolls people from the clinic, and we're hoping to create an infrastructure where people can be followed over longer periods of time, where we systematically record and collect and use the data that we collect in clinic. For example, you know, do you need an ankle brace? When did you start using an ankle brace, etc.? And that will help us to better understand the disease, but also it creates an infrastructure to provide better care And what leads me to the next question, really, the next problem that I want to highlight here is something that we see across diseases and across rare muscle diseases is that the people we enroll in research studies and in-person research studies is a small subset of people actually living with the disease. And when we typically do research, we have people come to our research centers, and we, people who donate their time and effort to come, those are people who usually can afford participating, financially and socioeconomically. They are usually mobile enough to travel to research centers. And as you can imagine, that's a smaller group of people than actually the people living with FSH. And that's a little bit of a problem, as this probably not reflects the whole group of people living with FSH. And that's a problem when we think about the future, when we do have drugs that we can give to people with FSH, and we need to distribute it as much as possible. And anyone with FSHD should have access to that drug. And we need to know whether it's actually working, not just for this small group, but for a larger group of patients. And what is our infrastructure to accommodate that? Because we don't want the drug just to be available for a small group of people. And we do want to make sure it's safe as well. And so oftentimes making sure, even after a drug is approved by the FDA, it's oftentimes necessary to keep monitoring the effect of a drug and also the safety. And what is our infrastructure for that? It's important to prepare for this and have the environment ready to do this efficiently and effectively and safely. And so when we think about people with FSH, so this is the research population that we see, and I mentioned, what it takes to be a study participant. In clinic, we see more because, in contrast to research visits, we see a larger group of people with FSH because we see everyone who has FSH who can take time to come to the clinic or have a telehealth visit remotely, for example, annually. And now, in times of the pandemic, again, remotely as telehealth visits. So MOVE has the goal to expand our bubble from this small research bubble here to include clinic patients and open up the access to research, include people that haven't been reached before, that could not afford coming to research centers and that couldn't take off from work, and also kind of overcome that artificial barrier between clinic and research, because the same assessments, the same questions that we ask in clinic, we ask in research. And lastly, though, not everyone who has FSH can come to a clinic, specifically not to a clinic in our centers. But they might see a local neurologist in a rural area who practices locally, not necessarily even a neuromuscular specialist. So how can we connect and make sure that we provide the best care, engage as many people as possible in research and in clinical care? And how can we reach out to anyone with FSH anywhere? That was another question we had. And to do so, we added a sub-study to the MOVE study to evaluate remote assessments in FSHD. What does that mean? We reverse the traditional relationship of research where we have you travel to us and we will travel to you by sending a toolkit to your home, and then we schedule a remote research visit where we connect by our Zoom, and we do a lot of the same assessments that we do on site in person remotely with video supervision. And so that's a small pilot study. That's a sub-study of the MOVE protocol. And basically, this is a great idea, but is it really feasible and does it work? And that's what we're assessing here. So basically, to summarize, what's new about MOVE? Well, MOVE is clinic-based. It engages, or the hope is to engage more people into our research community, to open up the access to people that have not been included in research before, and also to set the stage really for longitudinal data collection. So I know this is set up for 3 years, but if it's clinic-based and we have it all up and running and moving along nicely, there is the possibility to extend it and continue to collect data beyond those 3 years. And then again, the remote pilot is really the goal of the MOVE study, is to reverse this traditional relationship of traditional research. Now, why is this all important? You know, basically, why are we doing this? Well, the overarching goal we haven't lost focus on, which is really to have a drug that changes the lives of people with FSHD. And drugs are developed in the lab, and basic science is important, but with equal importance is really the clinical research and the clinical sides, and really preparing us and the community to be able to test those drugs and to ask the question, for example, how can we test whether a drug has a meaningful effect in people with FSH? What are the right measurements? How can we prepare to adopt these therapies then into clinic and really make sure they're safe and effective in a larger group of patients? And how can we really engage everyone with FSHD anywhere to be part of this community if they like? And how do we do this? Again, with the MOVE study, we want to answer the question, how do genetic characteristics, gender, age, or performance on these motor function tests predict how people do, you know, later in life, and whether they develop those motor milestones that I mentioned, such as use of wheelchair braces, respiratory support. And then we want to understand what's meaningful to patients. So patient-reported outcomes will be part of the study, asking you, what is your experience of the disease and what changes over time? And then again, we want to expand the engagement, as I outlined before, and we want to be ready to adopt therapies once they're FDA approved into clinic, and be able to monitor efficacy and safety even when a drug is approved, to make sure it's the right one for that person. And where is the MOVE study taking place? Here is the FSH Research Network and the sites. So wherever you live, some areas are a little bit, you know, you have to travel a little further. But there are sites across the United States that anyone can enroll with FSHD. And how do we achieve those goals? Well, the outline is that people come to clinic, and the study visits accompany the clinic visits. So it varies from site to site because it should be as flexible as possible to not exclude anyone. And basically the research, the tests can be done in clinic, or people can move over to the research center depending on the site and what it looks like. But it's supposed to accompany the clinic visit. And if people do still have telehealth visits through video recording, people can enroll through that mode as well. And then the goal is to have at least annual visits. But there is no limitation. So if people come back after 6 months because they need to see their clinician, then that data will be collected as well for the study. And what is being done, it's sort of an extended clinic visit. So we do obtain the clinical history, the same questions we ask in clinic, we ask in the study, we ask about the need for any devices or assistance. And then DNA is collected and the saliva sample is collected because, as I mentioned, we're interested in the genetic predictors of disease. And those will be linked with those clinical outcome measures. And then there will be questionnaires on symptoms and function, but specifically also on pain and exercise. And then respiratory function is being measured, and strength testing and functional tests will be done. And here I will transition to the expert, and Kate will tell you more about that.
I am Kate Eichinger. I'm a physical therapist at the University of Rochester, and I've been involved in clinical research and clinical care for individuals with neuromuscular disease and FSHD for many years. So I was just going to talk a little bit about kind of what happens during a research visit when we do the strength and function testing. So we'll be looking at strength and function, like Dr. Hamel said. to really kind of get an idea of how this changes over time and how these things may predict some of those harder motor outcomes that we talked about, use of bracing or use of a wheelchair and things like that. So we better understand how things change over time. So for this study, we'll be assessing strength with manual muscle testing. And so that is where we use different positions and pushing or pulling or manual resistance to examine the strength of the many different muscle groups. And you can see here that on this slide is just a different positions that we use to assess strength. And certainly if you have difficulty getting into these positions, we help you get into them. And then we take a close look at how those muscle groups are working. And as you know, many of the different muscles are affected by FSHD, but it's very different from person to person. So we try to understand the muscles that have been affected and how those muscles change over time. Again, that is something that seems to be quite variable in individuals with FSHD. So the results of this type of testing can give us information about the pattern of muscle weakness, as well as how those muscles change over a period of time. We also, you can go next slide, we also will use standard measures of function. And again, many of these are time tests that we've used in previous studies for examining individuals with FSHD. So we measure how long it takes a person to perform different tasks. And a lot of times we can associate time with the amount of weakness or the amount of impact that the disease has on a person. So things that we time are how fast a person can go from lying down to sitting up. A lot of times you understand that the core muscles may be affected. And so this can help measure that, because it's something that is impacted in people's daily lives. We also measure how long it takes to get up from a chair, walk a short distance, turn around and come back and sit back down. And that's kind of a complex movement that we do in our daily life. We also do a very fast walk of a short distance to better understand just walking ability, how people climb up and down stairs and how long that takes, we measure. We also measure just going from sitting to standing. And again, that gives us information about different muscle groups and how they work for a functional task. We look at picking up items from the floor. And particularly for the study, we use a pencil, but it's a daily task that's many individuals may have challenges with. And how long it takes to put on and take off a coat. As well as how much time it takes to stack cans. And while that's not necessarily something that people do in their daily function, it's a way for us to understand kind of functionally how the arm may be impaired. And because we want to know more about the upper body, we know that people with FSHD sometimes have difficulty reaching over their head, either to the side or in front of themselves. And so we're looking at reaching tasks. And we're looking at the ability to carry different objects by using a weight to measure how you're able to pick up an object. And then lastly, we look at hand grip strength. So we know that many individuals with FSHD do not have full grip strength. So we use a dynamometer, which is this picture in the lower corner, to measure that grip strength or the amount of force that can be generated by squeezing something. And next slide. We also, as part of our assessments, will be asking participants to perform various pulmonary function tests. This allows us to better understand the muscles that are associated with breathing. So forcing air out, coughing with different coughing and producing an airflow from that, as well as inhaling and exhaling with a force, can give us information about how the different muscles associated with breathing may or may not be affected. Again, something that is very variable across individuals with FSHD. And I think that's all I have, but it is a little bit shorter of a testing protocol for individuals that have participated in research visits in the past. Again, this has been designed to really capture kind of an extended clinical visit to gather a little bit more in-depth information during a regular clinic visit.
Perfect. Thank you, Kate. And then we'll just talk briefly about the sub-study, the pilot study of remote assessments in FSHD. And again, the purpose was to engage a larger community and engage more patients that have previously not been able to participate. As I mentioned, we do that by reversing the directionality of the research, and we ship out a toolkit with devices to participants. And then we schedule a remote visit via Zoom, and you will meet through the Zoom meeting. From our side, it's Kate, me, or another colleague of us, Peter Cree, who conducts those visits. And I think I sort of went through why we're doing this, but in addition, of course, to also eventually have a tool to reduce the burden on research participants, specifically those traveling from more rural areas. And then also to be able to collect more data points, because as you can imagine, we just test you on one day. And sometimes function can fluctuate, or people can feel better on some days and worse on others. And so increasing the amount of data points can help with that variability. And of course, I don't have to explain that this might be of interest when there's another pandemic, which we hope we won't have. And who's eligible? Anyone in a MOVE participant at Rochester or KU, University of Kansas. And at the moment, the requirement is that people need to have Wi-Fi that the iPads that we ship out can connect to. The overall goal eventually is to actually have people even participate who don't have Wi-Fi at home, because we don't want that bias that only people with internet can participate. But at the moment, for this pilot study where we're just checking how this approach works, people need to have a Wi-Fi connection in their homes. And who's conducting the study? As I mentioned, the study team at UFR is Kate and me and Peter Cree, and Leanne is the research coordinator, and Michaela is helping at KU as well. What will we be doing? Similar assessments. We have a physical examination, and then functional assessments that we have modified to be able to be done in a remote setting. And then we also do respiratory assessments, and then also we measure exercise and activity levels by ectography, which is measured over a week. And that's what we do remotely. And the MOVE study is supported by the FSH Society and Friends Research Institute and FSH Canada. And the PIs, the principal investigators, are, as I mentioned, Dr. Stadland and Dr. Tawil. And with that, I would like to move over to the question portion. And I will stop sharing my screen in just a second. Yep.
Great.
Yeah, thank you for all of you for joining and your interest in learning about this.
Thank you so much. Thank you so much for that. You might have mentioned this somewhere, but I just, as a reminder, how many patients are you seeking to recruit for the MOVE study, and how many for the remote assessment pilot portion?
So for the remote assessment pilot, we are hoping to recruit 20 individuals. Mm-hmm. And again, that's kind of a limited edition at the moment, because we're recruiting from Kansas and University of Rochester, because it's mainly focused on feasibility. And then, but once that phase is completed, we hope to expand and have more opportunities for remote assessments, including at other sites. And for the REMOVE study, I think the goal is about 300, but I think that there is no limit, and that the hope is to continue doing this, and also extending the study if possible to get more longitudinal data, and just so this study is meant to set the infrastructure and the protocol. Yeah.
Great. So there was a question, I think behind it is the question of whether children can participate in this study, or is it just adults right now?
Yep, anyone with a diagnosis of FSHD. So the criteria is really anyone with a clinical with a clinical diagnosis or genetic diagnosis. So genetic confirmation is not a requirement. So anyone with a clinical diagnosis of FSHD.
That's great. And actually, speaking of children, can you speak to maybe the importance of getting more data about children? Why is that important?
Yeah, that is very important because, and there we go back to the question, how much do genetic characteristics predict disease severity? And that is specifically important for children because there are different ways to measure disease severity. One is, just how weak is someone, and does someone has extramuscular manifestations such as the eye disease, the Coat syndrome, or hearing loss, or even in rare instances, cognitive issues. That's part of disease severity. But another measure of disease severity is age of onset. So how old were you when you had your first symptom that you attribute to FSHD? And that can be variable, as you know. Some people may never get diagnosed or have such mild disease that they only get diagnosed after another family member is diagnosed, and then they go to see a physician and they are being told that they have mild symptoms, but it's not really affecting their life. So that's on one end of the spectrum. And then on the other end of the spectrum is the more severe forms in childhood or birth. And what do we need to learn about this? What are the predictors? Why does someone develop the disease at young age, and why does someone develop disease at older age? Part of the theory right now is that the length of the repeat that someone has on the DUX4 gene plays a role. So, for example, 1 to 3 repeats usually goes along with a more earlier onset and more severe disease manifestations, while the other end of the 8-9 repeats is usually more milder. That's a generalization. And then in the middle of that, in between those two ends of the spectrum, it's really hard to say. And it seems that other factors other than just repeat length might play a role. And there we go into epigenetics. And it gets complicated because other genes not related to the FSH gene, to the DUX4 gene, but other genes on other locations, other chromosomes might play a role in that. And specifically genes, we know after discovery of FSHD type 2, we know that methylation levels can be affected by other gene mutations, and so there are different components that can modify the disease severity in FSHD. And part of this, you were wondering, well, we're collecting DNA and we're collecting RNA and we're collecting saliva. Why is this needed? Because to draw these what we call phenotype-genotype relationships, which means like we link the genetic characteristics, so the repeat length, methylation levels, and even other mutations on other genes, we link that to what actually a person experiences. And also when we think about care, and again, that's a clinic-based study, we think about care. How often does someone need to have monitoring? Do we all need to have our eyes checked? Or, are cardiac issues really something that needs to be monitored for? So all of that is important to come up with more targeted specific guidelines depending on what disease someone has. And it might differ. Not everyone needs the same who has FSHD. And so learning about those forms that occur earlier in life affect more other organs beyond the muscles, such as Coat syndrome in the eye, is important to understand this better. And then when we think about drug development, this is also critically important because maybe there are other than knocking down the DUX4 protein, maybe there are other target genes that can be targeted to modify the disease severity. And so to end with one more, I know I talked for a long time, so one last thought. So basically, eventually what is often done in rare diseases where there's so much disease variability is eventually a genome-wide association study where people actually look at all the genes, and then they try to find out, this person is, and then they find out what's unique about this population and other specific genetic mutations in that population that seem to be associated with more severe disease. But to do that, you need a lot of people with FSHD, and hundreds and hundreds, if not more. And so the MOVE study might be a way to do that in the future and to help achieve that goal eventually.
And that's one reason you're collecting blood samples, right? To be able to do that study. And that would be huge. I think we've talked a lot in the past about family studies, because one of the amazing things in FSHD is in a family, every member has the same basic construct to give them FSHD, but you might have someone who has barely any symptoms and someone else in the same family who has severe symptoms. And the answer might lie in their complete genetic makeup, that someone is protected. They have some gene, something that is protecting them from developing more severe symptoms, or vice versa. The person with severe symptoms has something that's accelerating and worsening the development of symptoms. So, and in the past, the studies were done in centers. The society actually paid for travel for people to go to Baltimore to participate in this study. Very expensive. It's a big commitment of time for the whole family. Everybody had to plan a trip to Baltimore. And now it sounds like with MOVE, you put in place the infrastructure to be able to do this kind of study across the country in many centers, right? So that's,
and I think
that's
that
huge.
If you think about, and I might not have mentioned that, but if you think about genome-wide association studies or learning about what really drives disease severity, it's important to have people included that actually live a disease at the end of the spectrum. So either mild or actually severe. And in natural history studies, the problem is that we like to collect all this data. We like to be people to be ambulatory. And so a lot of the inclusion criteria have been targeted on that. And so people that were in a wheelchair, for example, couldn't participate. And so the MOVE study really is more inclusive. And that's important when we think about learning more about the genetic predictors of disease.
There was actually a question asking if there are any upper or lower age limits from, it sounds like there really won't be. Anyone
No, and we want anyone who comes to clinic, and that's really the new thing about the study, that it's very inclusive.
Now, just circling back to the question about younger children, are there aspects of the assessments that can't be done by children, or certain types of testing, or?
No, I think the testing can all be done. We may just on the analysis end look at things slightly differently to be able to take into consideration growth and development that also occurs in younger individuals. So I think that will just really come out on the way we analyze the data, but the actual procedures can be done by individuals that are younger.
Okay. Now we have a question from Greg, who says some of us, in fact, I think many, have participated in multiple studies before. And they've also obviously been going to clinic regularly. Is there any way for the MOVE study to access that data?
That's a fabulous point and question, and that's something that we've struggled with across diseases, because sometimes people have donated their time and effort for decades in research, and we have lots of data points throughout their lifetime, and it's important to kind of connect these and really make sure we use all the data that you provided. And I believe the MOVE data, and we've gotten better in writing it into the study and consenting people appropriately so that we're able to link data. And I believe the MOVE study does that because, again, the goal is also to have this data available. And if in the future, for example, if something new is learned, or if there is a genome-wide association study, that the data can actually be used for that. So, yeah, but the other point I would like to mention is, for example, the one thing to get around the issue that you only have a small time frame in a person's life in those natural history studies, the registries, right? They try to overcome this problem by following people over years and years and years. And that's usually that people fill out annual surveys and report back how they're experiencing the disease and whether they started using a device, etc. So the registries provide that data, but it's all without clinical data. So supplementing some of that registry data with clinical data or even genetic data can be very powerful, and we could learn a lot from that. So I don't think we're there yet, but I think you raise a really important point. June, I think you're muted.
There's a question from someone asking if the study's only open to patients in Rochester and Kansas. Can you clarify that?
Yeah, I can go back. Let me see if I should, I can just go back to this and just move back to the slide to give you, oops, there it was. So these are the sites, the MOVE sites. So here in University of Washington, so these are all the sites someone can enroll to the MOVE study. Stanford, UCLA, Utah, Colorado, UT Southwestern, KU, Ohio, VCU in Richmond, Kennedy Krieger, Gainesville, University of Florida, and then we're up in Rochester.
Great. And a question, I guess this is for the remote assessment. Do you have some criteria around how far away they can be, or can it be any patient who's seen at either Kansas or Rochester?
Yeah,
and they could be in California.
Yeah, exactly. You can be anywhere, except we have not allowed people in, travel outside of the country. But if you're in the United States for a period of time where we would conduct that visit, that will work. And if you're a MOVE participant at KU in Rochester for the moment, yeah.
Okay. And very importantly, how do people sign up for the study?
I guess I should have put some contact information in there, but I can share with June.
Yes,
yes, we'll set you up so you can contact any of those centers. There's also, by the way, MOVE is also listed at the clinicaltrials.gov. If you're familiar with that site, anyway, I recommend it to my patients usually to get comfortable with that site, because you can always look up what's happening and if there are new studies listed on the clinical trials website. So MOVE is listed there as well, and it has all the contact information, but we can also share with June the contact information from each site.
Yeah, I think previously Michaela Walker at Kansas said people could send inquiries to her.
Send her to her and she will redistribute. Okay. Yeah, maybe that's easier. That
might be easier, especially for people who want to do the remote, maybe go through one person who can say, well, enrolling in the Kansas site or the Rochester.
Yeah, and so I have to say at the moment though, and I might not have been clear. So for the remote study at the moment, we do enroll participants who come to KU at Rochester for the MOVE study visits.
Okay. Got it. Okay.
But you can be in California. You can be for the remote part, you can be in California, but if you go to the California site, we could not at the moment enroll you for the pilot, although again, that will change once we complete that first pilot study. But Kate, I'm sorry.
I was just going to also add that the first study visit could also be done remotely. Obviously, in the time of the pandemic, we have been doing that, allowing that first clinic visit to be done remotely and through via telehealth.
Okay, great. And how long will that pilot study, how long is it planned to go on for before
until we've met our goal of 20.
Okay.
We have a couple people in it already, but we're still not mid through yet.
Okay, great. Yeah. So that would be one where probably a lot of people would be very interested if they knew about it and they could help get that completed quickly so that the remote assessment will be more available to more people.
Yeah, no, we've enjoyed doing that. Yeah.
So here's a question about the RESOLVE study, which it sounds like this person may have been involved in that said the evaluations look very similar. Can someone be enrolled in both the Resolve study and the MOVE study?
That's a good question. I think I would defer that to Michaela and Leanne. I'm thinking that they've been trying to, because Resolve is already finished, I think, enrolling, and so they're just following. I think my understanding is that they do it subsequently, but I would defer that to the study coordinators, and they have all the overview where someone is in the study and how to set it up. Yeah.
But I guess I would add that the hope is that it will also be, because like you said, the studies are very similar, the assessments that we're doing are very similar. So the hope is that the MOVE study will actually become an extension of the Resolve study. So people who have participated in the Resolve study will roll over into the MOVE study. But again, like Dr. Hamel said, I'm not too sure. I think it is one after the other versus simultaneously. Okay. But again, Michaela could better answer that.
Okay, all right. Here's a question regarding the assessments. There seems to be a lot of focus on ambulation. Will wheelchair riders be included in the initial stages of the study? And I ask because hand function plays a critical role in a person's ability to live and function independently.
Yeah, so our hope is that the arm function, the reaching activities, the stacking cans, the hand grip, all of that will be part of for people who may not be ambulatory. Also just looking at the ability to maybe stand even though if they're not able to walk. So certainly we hope that all individuals with FSHD would participate, and we would be able to use important information from them for this study.
Great. And I think one more, I think every patients all want to know about treatment. And there is a lot going on there. That's very exciting. But could you explain how the MOVE study relates to the development of therapies? How does it relate to clinical trial readiness and the success of clinical trials so that treatments are available to patients?
I think that it's important to know what to measure and to be confident in our measurements. And that's what the MOVE study does. We're evaluating the meaning of those measurements in terms of what does it mean to patients? Is it meaningful? And then second, also, how do these measurements predict actually that someone will have more trouble later in life? And meet those motor milestones. And then also it goes back to the genetic criteria. How do these genetic characteristics have an impact on disease severity? And why is that important? If you have a clinical trial and you have the more disease variability you have within a trial, the larger of a sample you usually need. So more people need to participate in a trial. And if you have variability of disease, but you don't understand why, that can impact the result of a trial. So the better we understand the variability, the better understand why people are experiencing the disease in a different way is important for clinical trials to test drugs. I think that's one part. And then the other portion is really getting ready not just to do a clinical trial, which usually clinical trials, they have strict inclusion criteria. Certain people are enrolled in a clinical trial. And then, but also getting ready for, once there is a drug that might be approved, to be able to distribute that to as many people with FSH as possible in a safe manner and in a controlled manner, so that we can, and they call this, post-marketing surveillance studies, where we measure what does it actually do in real life. The drug was tested in a small sample of people with FSH, but does it really do good in people, with any kind of FSHD and different disease severity? And so to have that infrastructure to distribute the drug in a good fashion, and then also be able to monitor it is critical. And so the clinic-based approach is important for that, but also the remote assessments might be helpful in that as well.
Great. Do you think the MOVE study will shed light on whether there are subgroups in the FSHD population that you can predict will progress faster? And maybe so in a clinical trial, you know, one might want to focus on that subgroup because you can show bigger change.
Exactly. And then also exactly whether there is a subgroup and what are the characteristics and are there genetic or other predictors for that. Because again, and that points exactly to the point I tried to make, if you have variability in a clinical trial and one is a fast progressor and one is a slow progressor, and you don't know why, it's going to affect the success of the clinical trial.
Great. Thank you so much for that presentation today. And we have no more questions. I do want to mention that, you know, there will be probably at least three clinical trials launching in the next 6 to 12 months, maybe 18 months. They will be earlier phase. I mean, obviously, all of these will have to do a phase 1 safety study, but I think they're planning to do phase 2 studies in 2022. We're going to see them. So I personally feel a great sense of urgency about getting as many people into the MOVE study. We don't want it to drag out for many years. We want, if you feel like this is something you're going to the clinic anyway, might as well sign the consent form, participate in the study, and just make sure we develop this really critical knowledge in time to, you know, benefit these clinical trials that are coming along. That's my little pitch. Do you have any other final thoughts before we end for today?
No, I would just say yes, exactly. And if there's more clinical trials, it's a luxurious problem, but eventually the burden of doing those clinical trials, it needs to be distributed so that, you know, everyone carries a little bit of that. And I think engaging people into the research is critically important to also have enough people participate in those trials so that we don't have any delays. Yeah.
Great. Well, I think you've really outlined what makes MOVE different. It's wonderful that it can, you know, this kind of research participation can now be accessible to so many more people. So I hope they will take advantage. People will take advantage of that. Great. So just a few quick announcements about what's coming. We have, let's see, I don't have the dates right in front of me, but Wellness Hour is the second Monday of each month. So I think that's the 14th at 5 p.m. And on June 17th, we will have another FSHD University webinar. This is a special one called Clinical Trials 101. And Dr. Tahsin Mozaffar from University of California, Irvine will be talking about the basic concepts that we all need to understand about clinical trials, how they're done, why they need to have exclusion and inclusion criteria, what all the lingo around it. I've been tossing around terms like phase 1, phase 2, or what do those actually mean? Where does the FDA enter into it? And what are the stages of the approval process? You know, what is orphan drug status? What is fast track? What happens after the phase 2 study? That we'll be learning results from that from Fulcrum before the end of this month. So do tune in to FSHD 101 so that you are up to speed on understanding all these concepts that are going to be flying at you fast and furious over the next couple of years. So with that, thank you so much. Thank you to our audience. Thank you, Dr. Eichinger, Dr. Hamel. And oh yeah, somebody saying, where do we enroll? We will post it on, this will be on the YouTube within a week. We'll post it there. We'll post a blog post follow-up to this. And also, as was mentioned, if you go to clinicaltrials.gov and look up, what would we look up? Would it come under MOVE or under?
Yeah, if you type in FSHD under disease and then MOVE, just MOVE, it comes up.
Okay. And there you'll be able to see all the trial centers, and you can pick one that's close to you and contact them.
I was to say the contact information should be there. Yep.
Yes. All right. Great. Thank you very
Johanna.
much.
Thanks, everyone.
And we'll
Thank
see you
you.
next time.
Bye-bye.
Bye.
Bye.